Hi, my name is Svetlana Bazilyan. I decided to do my presentation on interpulmonary percussive ventilation, which stands short for IPV. This procedure is actually fairly new to me too. Our hospital just recently starting doing these kind of procedures, and I actually agree with it a lot. And I've been seeing very positive changes with patients who receive IPV for their diagnosis once they get admitted. And I like to compare their x-rays and see that it actually works, and even the patients give us positive feedback how well this therapy worked for them. So I'm going to start off with explaining how IPV works. So basically IPV delivers air and aerosol to the lungs at frequencies of 200 to 300 cycles per minute, and the peak pressure for the rotations are from 20 to 40 centimeters of water pressure. So it actually it's pretty quick. I actually tried it on myself once, and it's a lot of turbulence. You can actually feel the turbulence going through your airways. And this is just a picture showing how when the pressure goes in and the turbulence is created, it helps to bring up that mucus to the upper airway so the patient can cough it up. So a little bit of information about IPV. This is actually the one that our hospital uses, and IPV was actually designed by F.M. Bird in 1979. And so the two main purposes for IPV is to treat active pulmonary disease and also to prevent the developmental of disease from which there are a lot of secretion retention. So basically, when we get patients who are admitted with these that fit into these two criteria, we either recommend for the doctor to order IPV, or the doctor just orders it on their own. Some of our doctors still are not familiar with it and they don't know what it is. So actually, I was thinking this presentation will be good for me to teach myself. So next time either a nurse or a doctor asks about it, I can freely explain some basics about how IPV works and what it does and why it's good for the patient. So IPV goals is basically is used as an alternative delivery system for bronchodilator therapy. So basically to substitute for SVN therapy. Also, it provides intrathoracic percussion and vibration for patients who need such therapy. It's also considered as an alternative way of providing positive pressure to the lungs and promoting the mobilization of bronchial secretions, which is the main purpose why we use it in our hospital. And also it improves the efficiency and distribution of ventilation. As we saw in the picture how that peak pressure distributes throughout the lungs very effectively, that's what happens with that the pressure distributes throughout all the lungs evenly. So this is, I found a picture with a patient using it. This is probably a home unit. And actually I've noticed that a lot of our patients who come in with trachs or who have, for example, cystic fibrosis, they actually come in with their own IPV machine. And I hear a lot of positive feedback about patients who use IPV at home. So basically IPV can be administered with 4 different ways. So first way is the mouthpiece. The second way is the mask, and then the third way, artificial airway, and through the ventilator. So basically, we are the ones who get to determine which is the better way for the patient to receive the IPV. So if the patient is completely alert and is tolerable of holding a mouthpiece in their mouth tight, then we recommend for the patient to use a mouthpiece. Sometimes we have to help them to hold if the patients are really frail. But as long as the patient can have a tight seal around that mouthpiece, we think that this is the best way for the patient. Because if they have to cough something up, we can easily stop it and take the mouthpiece out and have the patient cough up secretions. So mask, we only use the mask in the instances when the patient is not able to basically not competent, so they can't have it. They can't close their mouth completely, to have that tight seal over the mouthpiece so no air leaks out. So basically, if we use the mask, we have to hold it up to the patient's face, so the pressure stays intact. So it's not very comfortable for the patient, but I mean, if that's the way we have to administer IPV, that's what we use. Artificial airway is for patients. I see this a lot when patients come in from home with their trachs, for example, and they have an artificial airway. So this is a whole complete setup. They usually bring their from home, or we have to just kind of put it together with what equipment that we have for that. So that goes directly to the trach. We have some adapters that we usually just create a circuit if the patient didn't bring their own or whatnot. And then, of course, if the patient is on the ventilator, then it's a whole different circuit that we connected to the ventilator. And usually, it's very important to deflate the cuff a little bit so the pressure that's delivered to the patient doesn't overinflate patient's lungs. So this is how actually, when you would be looking at the ventilator when the patient is receiving the IPV, this is how the graphs are gonna be looking. So this is like every breath is triggered here. So that's how the flow, the airway pressure, and the tidal volume basically. So this is the tidal volume that the patient receives, and these are all these tiny breaths that are given to the patient. So basically, I like to do, when I do the IPV on the ventilator, I like to put the patient in the CPAP mode. But when the patient is fully dependent on the ventilator, then we just use the PRVC or assist control or whatever the mode the patient is in. Usually the patients tolerate it pretty well, and I like to suction a lot before I start the IPV, because usually the patients who receive the IPV on the ventilator have a lot of secretions and are on the heated circuit, so they already produce a lot. So then after the IPV is done, then I suction a lot too, or sometimes even I stop the IPV treatment and suction them throughout the whole treatment. So this is just a picture I found how the IPV, the pressure that comes with IPV helps to break out those mucus plugs that patients have in their airways. So that's actually a great picture how it explains how it just, breaks through the mucus plug and then helps to bring it up with the forces. So next, so this is actually a very good picture that I found, how it's a 3D CT scan analysis of a pre and post IPV therapy. So if you can see here how the before and after picture, the green is before and the red is after, how you can barely see the branches here, but here, once the IPV therapy was received, you can already see, because the reason why you couldn't see it before is because it was covered in mucus. But now, or here, basically like a whole section of a branch is missing, and now here you can completely see opened up. And then here it's like just also like the mucus plugs were like probably covering it, that you wouldn't even see the airway, and now here it opened up. And then here also it's the branches that look, it's like a whole section of it was missing. And after IPV therapy, you can see basically through it. Anyway, so I thought it was a great picture to show what actually IPV does to a patient, while, before and after. It's a great comparison. So basically, and then I also wanted to list some indications, like who would be a perfect candidate to receive the IPV therapy. So here I just found some basic, basic diagnosis of patients, or when patients get admitted, I can kind of, pinpoint who would be a great patient for the IPV therapy. So some of the patients that I think would benefit from it in a great deal would be mechanically ventilated patients with atelectasis, bronchitis, and bronchiectasis, which some of these patients actually who have this chronic disease, they actually take IPV at home pretty regularly. And then bronchopneumonia, chronic obstructive pulmonary disease, which is COPD, and cystic fibrosis is pretty much a must. As we know, with cystic fibrosis, there's a lot of secretions accumulated with this disease. So IPV actually works great on these patients to help to bring it up. Then also neuromuscular disorders which produce pulmonary systems. It's also another good one because a lot of patients who have neuromuscular diseases are so weak and they can't bring up those secretions. So IPV is actually a great source for these type of patients. Then also post-thoracic and abdominal surgeries. It's a good indication too, but as long as the patient is not in a lot of pain and pretty stable after the surgery, because actually this turbulence that's created with IPV is actually creates some discomfort to the patient. So we have to make sure that the patient is not in pain. I actually had to postpone a few times after I think a bronch that the patient received, and then the doctor ordered it like almost right away to do the IPV therapy, and I asked the doctor, can we postpone it, because the patient was just already like had so much airway pain. So I thought that wouldn't be a good deal. Or the other one would be when the patient just got extubated, that as well, because the patient already has so much irritation in their airway, so we don't want to cause more of that pain that they're going through. And then another indication that I've found would be a patient refractory to traditional hygiene methods. So I think that's a good one, because a lot of times we try like the mucomist and the acapella and other, like for example intensive spirometry, and that's just not working for the patient. The patient sounds more coarse and we see that more secretions are accumulating. So that's when we actually think like, okay, maybe we should try IPV. Or sometimes we even like the vest therapy is not working very well for the patient, so then we try to consider something new, and I would recommend IPV. And then also a patient with artificial airways who are unable to maintain clear lungs. I already kind of spoke about that. A lot of patients who have trachs, they're very ineffective to bring up those secretions to the upper airway, so they actually benefit a whole deal from the IPV therapy. And like I said, I see a lot of patients who come from home with their trachs. They just regularly receive IPV. And this one, I mean, it's kind of common sense, that restricted lung disease with recurrent atelectasis, because as we can imagine, when patient has atelectasis, that we need that extra pressure to open up those the alveoli, and IPV works a great deal for that, because as we can see that the way it brings in the pressure at peak pressure is 30 to 40 centimeters water pressure. It's actually a lot to to open up those alveoli that are closed down. Also, and there are also some contraindications. I already spoke a little bit about the pain, like if the patient is in a lot of discomfort, like if the patient just had a chest tube put in or taken out, or the patient got extubated, or went through like abdominal surgery. Because I mean, if you can imagine, it's a lot of pressure coming into the patient that can exacerbate all those the pain. So that would be I should have also added that in there. But the other indications that I found that are like completely contraindicated are untreated pneumothorax, hemoptysis, like if there is any active bleeding going on in the patient, or also the active tuberculosis, which is pretty much common sense, because we don't want the patient to have that all exacerbated and us standing there inhaling it. So yeah, those are just some of the contraindications that I found. In addition to the patient is having a lot of discomfort and pain. And then some of the precautions that we need to look out for when the patient is receiving IPV is also the tube feedings need to be stopped for 1 hour prior to the IPV therapy, like with the chest therapy, because I mean it's a lot of pressure going into the patient, and if the patient is receiving the feeding, it can help the patient vomit and all sort of stuff, or aspirate. And also the patient should be on some oxygen when this therapy is provided, if the patient is not already. And also the vitals should be monitored closely, just in case that the heart rate is going up or the patient is desatting. That should be monitored very closely. And then patients should not receive IPV therapy after eating, and that's kind of common sense, so the patient won't vomit And during IPV, the vital signs need to be monitored. That's very important because we never know what the patient is going through. And then this is just, I found a good 2 x-rays from this study that I found. So this is this is actually only one IPV treatment, and we can see the 2 x-rays. This is so much more whited out than here. So this cleared out a little bit. That's after one IPV treatment. So this is like a significant change from this one to this x-ray. And these are just some references where I found the information. So thank you very much for watching my PowerPoint. Thank you.